I think we're going to go ahead and get started. It's just a couple minutes after 8. It's my pleasure to introduce our speaker today, Dr. Heather Stefanski. Heather did her undergrad at Smith College in Massachusetts and then came to the University of Minnesota to do several things. She first got her PhD in immunology here, followed by her MD, and then she did her residency in pediatrics and a fellowship in hemonc and transplant. She is currently assistant professor of pediatrics here, and her research has been focused on quickening immune reconstitution, specifically T cell function following blood and marrow transplantation. And this will be her topic today, improving immunity post bone marrow transplant. Welcome, Heather.
Thank you. Thank you. Let me know if you can't hear me in the back. I do have a pretty loud voice. So thank you for inviting me. I'm excited to talk about some research that I've been doing with Drs. Bruce Blazer and John Wagner. And really it started when I was in fellowship. And as Dave and I were just talking about, I've been at the university since 1993, so a very long time. And if you would have told me when I was getting my PhD that I was going to be here in 2017, I would have said you're crazy. But apparently I'm a lifer. So I do have a disclosure. I am a speaker for Kymriah for Novartis, but I'm not going to be talking about that at all. And it has nothing to do with the topic today. So the objectives today are to understand the manifestations of poor immunity post-transplant, to understand how T-cell immunity impacts relapse and infection, and to understand how umbilical cord blood can be used to improve immunity. So I am a bone marrow transplant physician. And really, bone marrow transplant is only used for those patients that would die without it. We don't use bone marrow transplant for fun because there are a lot of complications that go with it. So we mainly use it for hematologic malignancies or non-malignant disorders. And the reason that we use it for non-malignant disorders is because it's replacing the enzyme that needs to be or is resetting the immune system. So in order for patients to successfully have a bone marrow transplant, we have a conditioning regimen which results in myeloablation. And the reason for that is that we need to create space within the bone marrow so the new cells can start to grow. And in the when we're doing it for cancer, the reason for the myeloablation is to eradicate the cancer. So with bone marrow transplant, there's increased morbidity and mortality due to the increased risk of infections. And in fact, patients don't have a normal immune system until at least a year after transplant, and that's assuming that the patient doesn't have any graft versus host disease. Because if they have graft versus host disease, then we have to further immunosuppress them, which then doesn't allow their immune system to recover. And T-cell immunity is not fully functional until at least a year. So the T-cell immunity is observed in both the CD4 and CD8 compartment. And in bone marrow transplant patients, there is a lack of T-cells and functional peripheral responses to pathogens. So in a study that we did here that was published in 2005, Juliet Barker looked at infections post-transplant, either early, so days 0 to 42, or late, days 43 to 81. And she looked at 3 different stem cell sources. So looking at normal bone marrow, looking at T-cell depleted bone marrow, which we do use in some patient populations, and then looking at umbilical cord blood. And the reason for doing this study was that when we first started using umbilical cord blood as a stem cell source for transplant, people were very nervous because umbilical cord blood is very naive, and they were concerned that the cells wouldn't engraft or that patients would have more infections. And so what this shows, if I can do this, looking at bacterial infections, there's not a big difference between the 3 stem cell sources. So bone marrow is shown in black, T-cell depleted bone marrow is shown in gray, and then umbilical cord blood is shown in white. But there is a big difference in viral infections. So in patients that had T-cell depleted bone marrow, they had more viral infections compared to the other stem cell sources. And then there weren't any differences in the other types of infections. And then looking later, what we can see is that patients that received T-cell depleted bone marrow, that they were at higher risk of having bacterial infections and viral infections, not fungal infections or pneumonia. But then the total infections, what you can see is that patients that received T-cell depleted bone marrow, again, were at much higher risk of having these infections. And so what this data told us is that despite umbilical cord blood being naive, that in fact they weren't at a higher risk of infections, but still patients would have them. So another study was done by Parkman and published in BBMT in 2006. And what this study wanted to do was to actually take patient samples and then determine if they had functional responses to viruses, and then look at those patients' outcomes. And so what they did is they took T cells from the patients, and then they exposed them to CMV, EBV, and other viruses in vitro, and then determined if they had a functional response or not, and then compared the outcomes. And so what you can see here is that if patients had a negative response, meaning that they did not respond to the viruses, compared to those patients that had a positive response to the viruses, that there was a major difference in the probability of relapse-free survival. So those patients that actually had a functional response, suggesting that their T-cell immunity was intact, that those patients did much better. So taking these things together, what we want is we really want functional T-cell responses after transplant, in hope that we can decrease the amount of morbidity in our patients with viruses, and then also by preventing relapse. Because even though patients come to me for this life-saving therapy, I still tell them that their highest risk is relapse if they have a leukemia or a cancer. Now there's multiple factors that potentially affect immunity. One is the graft source. So as we said, umbilical cord blood, bone marrow, or in adults, they use a lot of peripheral blood stem cells, which we do not use in pediatrics. There's also graft manipulation that can affect it, so T-cell depletion, as I showed in that one of those slides. And we also can do CD34 selection. And then there's transplant-associated complications. So graft versus host disease can affect the immunity post-transplant, and so can infections. And then also the source characteristics. So the naivety of the source, and then the actual cell numbers of the source can affect immunity. So whereas in bone marrow, we can get a lot of cells from patients for the most part, in umbilical cord blood, if we're just taking one umbilical cord blood unit, there is a defined number of stem cells in that bag. And we can manipulate that, as I'll talk about later. But initially when we were doing this, if there were not enough stem cells in there, then the patients would not engraft, or they would have delayed engraftment. There's also host factors. So age is a big risk factor affecting immunity. So older patients, their thymus involutes, and they don't have as functional of an immune system as children do. Prior therapy, so in heavily pretreated patients, their immune system is also not normal, and then actually sex can affect it. And then the conditioning and GVHD regimens can also affect immunity. So in some regimens with our non-malignant disorders, we use a medication called Campath, which actually it's an anti-CD52 monoclonal antibody, and that depletes all of the lymphocytes. And then for some of the regimens, we have to use ATG, which then depletes the T cells. And when patients get these regimens, then it takes much longer for their T cells to actually come back. So where do we get T cells after transplant? So there's a couple of places. So what happens is that there's hematopoietic precursors that then have to go to the bone marrow, where they then undergo differentiation into T cell precursors. They go to the thymus, and then they become naive T cells. Now within the allograft, there's also T cells that are there. So there's non-alloreactive T cells, which then can undergo homeostatic T cell clonal expansion. There's alloreactive T cells, which we don't particularly like, and that's because they can cause graft versus host disease. And then if the patient didn't get all of their residual host T cells ablated, or they're still there, then they can actually cause an alloreactive T cell clonal expansion as well, but then they cause graft rejection. So really the cells that we don't want there are these alloreactive T cells that are going to cause graft versus host disease, and then residual host T cells. So the barriers to successful immune reconstitution are a couple of things. One is that there's this lack of T cell precursors. So if the graft doesn't have a lot of T cells in it, and it's going to take a long time for the T cells to come back, and then as the patient is undergoing this regimen and they're on immunosuppression drugs, then the T cells won't actually work. So one way to go about this is to have more T cell precursors. Another problem is that the thymus has stromal injury due to the radiation or the chemotherapy regimen or even the age of the patient. And really the thymus can't recover unless there's this crosstalk between the thymic cell precursors to cause the stromal cells to actually develop and become more of a normal thymus. So this can take a long time if you don't have these T cell precursors. Then the other problem is that the mature T cells, if the spleen and the lymph nodes aren't normal, then even if you have a lot of T cells, that could also be a problem because the T cells won't home to the appropriate places when there's an immune response. What I'm mainly going to be talking about today are the T cell precursors and how we can try to alleviate that problem. So the way that we did this is we used the OP9-DL1 system. This is a mouse stromal cell line that expresses a Notch1 ligand delta-like 1. And when cultured in vitro with mouse HSCs, large numbers of Tprogenitors are generated. When Tprogenitors are infused with bone marrow into irradiated recipients, there's an increase in thymic cellularity, normal T cell repertoires, and an increase in donor chimerism. And I will show you some of our experiments now. So I started this project when I was a fellow in Bruce Blazer's lab in 2009. And so originally what we wanted to do is, as how all things seem to work, you first have to test it in the mouse, then you have to find a human counterpart to do that, test it in a xenogeneic mouse model to make sure that it works, and then we can translate it to the clinic. So first we had to start with the mouse. So hematopoietic stem cells in the mouse are about 0.02% of the total bone marrow cells. And then really there's about 16,000 or 160,000, sorry, in the mouse. And then the way that we would isolate them is we use c-kit, is that we'd lose a bunch of cells. So really when I was starting these experiments, there were only about 40,000 per mouse. And so the way that we did this is that we would isolate the cells, we put them on the OP9-DL1 cells, and then put them with the cytokines IL-7 and FLT3 ligand. The cells are then in culture for about 35 days, depending on how long it is. And then we look at the T progenitor phenotypes. So the way that T cells develop in the thymus, I just want to briefly talk about this. So originally they're double negatives, and they come in through these high endothelial manules and these blood vessels. And what happens is the double negatives are based on two markers called CD44 and CD25. And so they start off, and then they're going to go in the cortex, where they become DN2s. They're going to be interacting with Notch ligand and CCL25, and then they'll become DN3s. They then start to have a pre-T cell receptor. They become DN4s, and really they're pre-double positive cells. And it's at the double positive stage where they interact with the cortical thymic epithelial cells, and this is where positive selection occurs. And it's based on these interactions, and truly that's the beauty of the thymus, that it will get rid of anything that is going to react to self, causing an autoimmune response. So if the ligand is too great, those cells will be deleted, and only the ones that are going to have low affinity T cell receptors for self are the ones that are going to be selected. Then these double positive cells become single positive cells and interact with the MTEX where they undergo negative selection. So just so you sort of understand that the thymus, how it works. So when we first did these experiments, so I started off with 200,000 cells, and really, by day 25, I got 465 million cells. So that shows that in fact we can generate billions of these cells, or millions of these cells really. And what they look like, so at day 7, the T progenitors are predominantly DN1. So DN1 cells express CD44 only. DN2 are double positive for CD44 and CD25. And then DN3 cells are CD25 positive only. and then DN4s are both, are negative for both. So again, this is just showing, looking at the population. So it's the predominant population at day 7 is the DN1 population, where 55%. Some of them are DN2s and very few are DN3s. But as they're allowed to go through these processes, then at day 10, most of the cells are going to be DN2s, some of them are DN3s, and then some are even becoming DN4s. And then by day 21, the predominant population is DN3. So what we wanted to do then is we wanted to test this in a transplant to see if these were actually able to improve immune reconstitution. So the way that we did this is, again, we took these cells, hematopoietic stem cells, put them with IL-7 and FLT3, allowed them to be in culture for 21 to 28 days, where greater than 95% of the population was DN2 or DN3. Then we put them in a lethally irradiated recipient, and then added both Tprogenitors and congenic bone marrow. So the reason that we have to add bone marrow is because when you irradiate the recipient, they're not going to have any normal hematopoiesis. And so if you don't give them hematopoietic stem cells, then they're not going to be able to make their red cells and platelets and other white cells. So you really need to give these at the same time. And then we looked at days 7, 14, 21, and 28 to determine the timing of thymic engraftment and peripheral reconstitution. So this is just looking at the Tprogenitors that I injected. So the predominant populations were DN2 and DN3. And then the Tprogenitors can be seen as early as day 7. So the way that we look at this is that the beauty about the mouse system is, just like the human system, is there can be different markers. So the Tprogenitors were CD45.1, unlike the rest of the mouse. And then the donor bone marrow was Thy1.1. So this mouse didn't receive anything. This is just a normal B6 mouse. This mouse received bone marrow only. And then this mouse received bone marrow plus Tprogenitors. And you can see at day 7 in the thymus that we can start to see these thymic progenitors. And then this is looking at the thymic profile. So this is what a normal thymic profile looks like. It looks like a bird. So most of the population, when you look at CD8 versus CD4, are the double positive cells. So this is a wild type mouse. And then when we look at host bone, there's not very much host there. But the donor bone marrow here looks like predominantly a normal thymus with CD4 or the double positive cells, and then some single CD4s and some single CD8s. And then in the mouse that received the thymic progenitors, again, you can see that these thymic progenitors, so even though they went in as DN2 and DN3, that they were able to undergo the normal thymic process to become double positives and then eventually single positives. So then looking at this, in mice that received, this is a normal mouse, so there's 40 million thymocytes here. And then in the bone marrow only mouse, there's obviously no pre-T cells or Tprogenitors. And here, I don't have it, but there's a significant difference. So in the mice that received these Tprogenitors, that there was better thymic engraftment, and the predominant population of the thymus is the Tprogenitors. And that could be because the Tprogenitors were already at a stage, which makes sense, that where they were going to go to the thymus anyway, as opposed to from the bone marrow, they have to undergo the pre-T cells to become, to be able to even go to the thymus. So then this graph is showing that all of the Tprogenitors are found in all the T cell subsets. So looking at the double negatives, there's Tprogenitors there. There's not very many of them. They're predominantly double positives, single positives, and CD8 single positives. And then by day 28, essentially everything left the thymus, or the Tprogenitors. So what happens then is once they become mature, then they're going to go out into the periphery. So the conclusions from this were that Tprogenitors do improve immune reconstitution and are able to engraft the thymus. And our preliminary data suggested that different stages of development dictate the ability of engraftment. So comparing DN2 and DN3s, DN2s were much better at engraftment. I didn't show you that data compared to DN3s. So then how do we translate this to human? So can we generate human Tprogenitors? So hematopoietic stem or progenitor cells, they're blood-forming cells that can duplicate by self-renewal, as well as produce all types of differentiated blood cells. So the hematopoietic progenitor cells are blood-forming cells that can produce all types of differentiated cells. So the HSC becomes an HPC that becomes a lineage precursor, so it can produce the white cells, red cells, and platelets that are in our bone marrow. So the characteristic, they're CD34 positive or c-KIT. Surrogates for evaluating number of stem cells, there's a nucleated count that we look at. So in thinking about my patients, the acceptable engraftment is 2 to 4 times 10 to the 8th, and nucleated cells per kilo, and that's based on the recipient weight. And then a CD34 cell count, so the acceptable there is greater than 2 times 10 to the 6 CD34 cells per kilo. And again, that's based on weight. So the source that I'm going to talk about today is umbilical cord blood. So in 1988, the first related umbilical cord blood transplant was done for Fanconi anemia in France. In 1993 to 94, the first unrelated umbilical cord blood transplant was done by Dr. Wagner. And really this blood that's from the umbilical cord blood and placenta are rich in hematopoietic stem cells. And so these, the cord bloods are harvested at birth and then they're frozen. And the target is 1.7 times 10 to the 5th CD34 per kilo, or greater than 2.5 to 3 times 10 to the 7th nucleated cells per kilo. So what we wanted to do is we took umbilical cord blood and we isolated CD34 positive cells or their progeny and placed them in culture. We cultured them on the mouse stromal cell line, again with FLT3 and IL-7. And then here for humans we had to add human stem cell factor. And then we're going to inject these into irradiated NSG mice. So what I'm showing here is that in fact I took frozen cord blood and then I put it in culture, and then I was able to get really great expansion. We got 16 million cells, and they expanded, mainly between day 10 and 15. And what this looks like, looking at CD34 versus CD7. So this is looking at different days in culture, day 10, day 15, and day 20. And then this is looking at CD7 and CD5 on these bottom panels. CD7 and CD5 are very important T cell markers. And pro-T1, which are the more immature population, are CD7 positive only. And then the more mature population are CD7 and CD5. So what you can see is that on day 10, the predominant population is CD34 and CD7. And then of these, most of them are going to be CD7 positive only. But by day 15, they're starting to lose some of the CD34 expression as they become the pro-T2 cells. And then by day 20, there's still some CD34 expression, but there's still the predominant population is pro-T2. So then the question is, can these go into mice? So we injected them into mice and looked at 8 weeks. And so here's looking at HSC alone. Here's looking at 2.5 times 10 to the 5th of the Tprogenitors plus HSCs, and then this is looking at 1 times 10 to the 6th plus HSCs. And this is looking at CD45. And then you can't really see it here, but in these NSG mice, they don't have a thymus, and it does have a thymus right here, very little lobes. And then looking here, looking at the CD45 positive, CD3 positive, there were 300,000. Compared to the HSC average alone. So even though this is taking human umbilical cord blood, putting it on a mouse stromal cell line, it still works, and we can put it into a xenogeneic model, and it's able to engraft the thymus. So the issues that came up with this is that with naive umbilical cord blood is that we would never be able to generate enough cells to do the clinical trial because it's going to be based on weight. And I don't think that there's a lot of 30-kilo people in the world. We could maybe do it in children, but most of the time for kids, they're not going to allow us to do a clinical trial like this. We're going to have to start it in adults. And so really, in order to do this, we had to come up with a different way. And so what to do next? So luckily, John Wagner and Dave McKenna have been doing this trial where they looked at expanded cord blood. And there's a number of strategies that we could use. There's cytokine combination mediated expansion, co-culture with stromal cells, not signaling pathway-induced expansion, which Colleen Delaney has done in Seattle. And what we did is we looked at an aryl hydrocarbon antagonist, SR1, or the Novartis name LFU835. And I'm also going to be talking about UM171, which is a primidinidol derivative that is also a stem cell expander. So in looking at this, the reason that we wanted to do this for our patients is that when the first umbilical cord blood transplants were done, they worked. And the beauty about umbilical cord blood is that unlike trying to find bone marrow for a patient, which has to be pretty perfectly matched, it's hard to find perfectly matched donors for everybody in the world. But with umbilical cord blood, because of the naivety, we can get away with much less of a mismatch. But the problem is that when we were doing it for adults, a lot of adults wouldn't be able to use an umbilical cord blood unit because it's based on weight. So if you don't have enough stem cells in that cord blood unit, then they wouldn't be able to use that. So then what we did is we actually did double umbilical cord blood transplants, which worked. There was a little bit more GVHD with that. So what we thought is that maybe if we could expand the stem cells using one umbilical cord blood, what would happen with that? And so the reason for that is that looking at engraftment, which is looking at the neutrophil count of greater than 500 for 3 days, comparing this to peripheral blood. So in peripheral blood, the cells engraft by day 13. In bone marrow matched donors, it engrafts by day 18. And in umbilical cord blood, it engrafts at day 25. And so even though that doesn't seem like a long time, what that means is the patient has to be in the hospital, they're at high risk of infections, and they're at high risk also of requiring more transfusions because their bone marrow is not working as well. And so can we alleviate that problem? So the way that we set this up is we took one umbilical cord blood unit that had to be less than or equal to 2 antigen mismatch, and it had to have a nucleated cell greater than this. And then we expanded it in culture for 15 days with SR1. We used cytoxin and fludarabine and TBI as part of the regimen. And then we looked at different doses of cells and then looked at the speed of peripheral recovery. And then the patient then got a different umbilical cord blood unit at day 0. And then got the expanded cells essentially like right after that. And then they also got cryopreserved CD34 negative cells. And the reason for that is that if in order for cells to engraft, you do need some T cells. And so we did not want to get rid of that CD34 negative unit in case that had the good cells. So the primary endpoint was safety and then infusional toxicity. So there was a huge impact of this. In fact, the patients engrafted on a median day of 10.5. So that was a huge difference with normal, unmanipulated umbilical cord blood. And what this did for the patients, frankly, is it got them out of the hospital sooner. It was safe for them, and they actually did really well. And for the most part, they engrafted with the second cord blood unit because that was going to have all the HSCs. This unit that was expanded didn't stay as long, which is sort of what we expected. And the other important things are that there was not an increase in grade 2 to 4 acute GVHD. There was not an increase in transplant-related mortality, overall survival, or grade 3 for acute GVHD. Because what you worry about is that when you're giving that many cells, and if it's mismatched, that in fact you could cause some really bad graft versus host disease. But we did not see this. So then the question was, okay, so could we use expanded cord blood as a source of T progenitors? And the reason that this would be helpful is because in the MCT facility, they can generate billions of these cells. And so if I can start off my culture with 10 million cells as opposed to 10,000 or 100,000, that could make a huge impact. So the way that we did this is we, again, isolated CD34 cells and their progeny, put them now with SR1 for 15 days, and then took the bulk culture and put this on OP9-DL1 cells for 14 days with the cytokines, so human stem cell factor, FLT3, and IL-7, and then we injected the T progenitors into irradiated mice. So this is looking at SR1 expansion compared to naive umbilical cord blood expansion, and what you can see is I got 200 million cells with my SR1 expanded T progenitors as opposed to 20 million with my naive. So in fact, this was feasible to generate large numbers of cells. But interestingly, there was a phenomenon here. So looking at CD7 versus CD34, so at day 7, the predominant population here is CD34, CD7 cells. And then by day 12, the predominant population is CD7 positive. There's very few CD34 positive cells. And then really by day 25, most of the cells are CD7 positive and there's not any CD34s here. So the reason that this was concerning is because Juan Carlos Zuniga-Plufker, who is one of our counterparts, he had shown that the cells that were needed to engraft the thymus were CD34 positive, CD7 positive. So when we got this data, I was a little bit concerned that in fact, even though we can generate large numbers of cells, that in fact they won't be able to engraft the thymus. So we tested this. So what we did is we took SR1 Tprogenitors, injected them with hematopoietic stem cells, and then looked at, this is looking at CD7 versus CD5, and I compared it to naïve versus SR1. And so looking at the cell dose, this is a different cell dose, and this is looking at the thymus and then the spleen. And so the white bars are naive umbilical cord blood, and the black bars are SR1 expanded cord blood. So even though the predominant population did not express CD34, that in fact they were able to engraft the thymus, albeit not as well as the naive umbilical cord blood. But more importantly, these cells were able to make it out into the periphery and become mature T cells. So we tested this, and then this is looking at the thymic profiles. So looking at CD8 versus CD4, and what you can see is that this is a little bit smushed, I'm sorry, but these are normal thymic profiles, despite the cells not having CD34 on their cell surface when they went in, compared to naive umbilical cord blood. And looking in the periphery, we were able to generate both CD8 and CD4 positive cells compared to the naive umbilical cord blood. So then what we wanted to do is we actually wanted to make sure that this was true, and we sorted the cells. So what we did is we took CD34 cells, expanded them in culture, again put them on the OP9DL1 cells, and then we sorted them into CD34 positive, CD7 positive cells, and then CD34 negative, CD7 positive cells, and then injected them into mice. And here, what you can see is that the CD34 positive, CD7 positive cells engraft the thymus, and although it's at lower levels, the CD34 negative, CD7 positive cells are also able to. And then this is looking at CD8 versus CD4. So even though these only have CD7 on their cell surface, that they are able to engraft the thymus. So the other interesting thing is that when you look at naive umbilical cord blood, that those cells, when you sort CD34 positive, CD7 positive, and CD34 negative, CD7 positive, that those cells aren't able to engraft the thymus. So there's something functionally different when we expand cord blood that makes them able to engraft the thymus. And it might be that there's some, and we're trying to investigate this, but you know, it could be that there's a protein on their cell surface. It could be that they're just younger. We're not really sure, but it's definitely a fundamental difference. So the conclusions are that SR1 expanded umbilical cord blood results in much larger numbers of Tprogenitors. The SR1 expanded Tprogenitors lose CD34 expression, but despite this, they're still able to engraft the thymus and spleen in NSG mice. And naive umbilical cord blood requires CD34 in order to engraft. Thus, again, there's a fundamental difference that we actually would not have predicted with the SR1 expansion. So then another interesting thing is we wanted to say, do other stem cell agents have similar findings? So we wanted to compare SR1 with UM171. So UM171 is also a stem cell expander. It acts in a totally different way. And we cultured them both on OP9DL1 cells to generate Tprogenitors. So this is just looking at stem cell expansion. So we either put them with SR1 or UM171, and then this is looking at the 15 days. So SR1 expands more than UM171, and then this is looking at the CD34 and CD90 expression on day 7 and 14, and there wasn't a huge difference. And it is known that UM171 sort of stops the generation, so it's not surprising. It sort of inhibits the proliferation of some things, which is why we didn't get as many cells as we do with SR1. And then this is comparing naive umbilical cord blood to UM171 and then SR1. So again, we get great expansion with SR1 Tprogenitors. UM171, we can generate some of them, and then naive. And interestingly, when you look at the phenotypes, so now this is looking at naive, these are the days, this is looking at CD7 versus CD34. So you can see at the end of day 20 culture, a lot of the cells are CD34, CD7 positive. Whereas in SR1 and UM171, despite them being totally different, they both lost CD34 expression. So we're testing that in mice now to see if those cells are going to be able to engraft. I would predict that they will be, but I haven't tested that yet. So the final thoughts are that slow immune reconstitution causes significant morbidity and mortality in my patients. I've seen it firsthand many times. My patients will die of the common cold, so adenovirus, for example, which basically causes pink eye and just normal cold, or even CMV, which causes the cold. My patients can die of this. So how can we improve immunity? So in order to overcome this, we have to expedite immune reconstitution after transplant. One way will be to use Tprogenitors, and then right now we're transferring this to MCT to prepare for the clinical trial. So the way that we're going to do this is we're going to take one cord blood unit and we're going to expand it for 15 days, and then we're going to take about 20% of that or a portion of that and put it into Tprogenitor culture. And we can use this with deuterated water, and what that can do is that will allow us to actually see Tprogenitors using MRI using an MRI when we can take a sample of the cells to see how many cells are actually Tprogenitors. So when you use this as a culture step, then the deuterated water is incorporated into the Tprogenitors, and it will just allow us to monitor them. And so what the patients will do is these will be patients 12 to 60. They'll get a myeloablative conditioning regimen with cytoxin, fludarabine, and TBI. And then they'll get their HSCs, or the expanded cord blood unit, on day 0. And then around day 12 to 14, they'll get the Tprogenitors. And so we're going to be doing an escalation dose trial. Our goal is to get to, hopefully 1 to 3 times 10 to the 6 per kilo, which I think we'll be able to generate. And hopefully right now what we're doing is MCT facility is going to be setting up an experiment where we're going to be doing a pre-GLP study to make sure that what we've done in the lab can actually be translated to them. And then hopefully we'll be doing the next, the good GLP study, and then we'll be getting our IND. And our goal is to have this in clinical trial within a year. So hopefully it will work. So I need to acknowledge John Wagner and Bruce Blazer. The CTM facility has also been very helpful. Beverly Norris and Bob Schumacher, and then Dave, Darren Sumstead, Diane Cadidlo. They've been very helpful with the MCT facility. Jasty and JC are our collaborators in Toronto, and they have been pivotal in these experiments as well. So thank you. Yes.
So for the clinical trial, you're giving the Tprogenitor cells about 15 days later, and I think in the mouse you gave it about the same time.
Yep. So the reason is that that's really the only way that we can do it, unless we had off-the-shelf T cells, because if we're going to be giving it to the patient and we first have to expand them, I don't know if we'd feel comfortable expanding them like 30 days prior, because we're giving fresh SR1 cells. And I don't actually, with the FDA, we're going to have to see what the feasibility is. If they're going to allow us to do 2-cell products within that time point, we might have to wait till day 30, frankly. But yes, ideally we would give them on the same day. And I think eventually we might be able to have an off-the-shelf product, because the beauty about the thymus is it's very smart and it will get rid of alloreactive cells. And so really you could use a major mismatch, and those cells will still be, the appropriate cells are still going to be educated in the thymus. So in the mouse experiments, Marcel Vandenbrink did a number of them where they actually took completely mismatched MHCs, and those mice were totally fine. They didn't get an increase of GVHD, and they had made it so the Tprogenitors could actually react to a tumor, and they eradicated the tumor. So there's a lot of potential applications for this. But yeah, I mean, ideally I'd want to give it on day 0, but at this point I just don't think that that's feasible. Yes?
So the signaling through AHR is important at many pivotal points in the differentiation, including also in the T-cell subspecification, different T-cell subsets. Have you looked into how does it alter the repertoire of T-cells in terms of CD4, CD8, Th17, Th2, all those things?
No, I have not. And I should say that in the T-cell progenitor culture, we don't have the SR1 in it.
But it was there before.
Yes, it was there before.
Lasting effect later.
Yes, yep. So I don't, but I have not looked at that. Okay, thank you.
Heather.
Thanks.